My name's Amy Sutherland. I'm a dietitian from the Northern Hospital, and this project was identifying and managing malnutrition in upper GI surgical oncology patients. The aims of this project were to decrease malnutrition rates to less than the state average of 65% and to decrease the severity of malnutrition so that no patients lost more than 10% of their body weight throughout treatment. Also to establish dietetics referral processes so that our highest risk patients were seen by dietetics within 1 week of diagnosis, and to decrease unplanned nutrition related admissions and length of stay to 0 days. The project was delayed due to requiring resubmission of ethics, so we are currently in the process of implementing strategies to meet the aims. We've collected some data and disseminated the results, and this is an example of the Excel spreadsheet used to collect data from electronic files. We included all patients admitted to the Northern in 2014 with a diagnosis of upper GI cancer, and excluded patients palliative for end-of-life care who had treatment at another acute hospital or had not yet commenced treatment. Data was also collected regarding diagnosis, staging, presence of metastatic disease, type of treatment and length of stay post-op. Specific nutrition information was collected regarding weight changes before diagnosis and post each phase of treatment, and also the types of feeding tubes inserted and times between diagnosis, dietitian referral and dietitian assessment. 55 patients were analysed, which is relatively small numbers. However, the service is growing quite quickly and we're now seeing more complex patients, particularly esophageal cancer patients. The average age of the patients was 71 years and 69% were male. The results were analysed in 3 groups based on what treatment we thought was the highest nutrition risk. So the first group were patients who had a surgery requiring significant resection or reconstruction of the GI tract, so total gastrectomy, esophagectomy or Whipple's procedure. The second group were patients receiving other types of treatment such as partial gastrectomy, hepatobiliary surgery or chemotherapy alone. And the third group were patients receiving palliative treatment such as a palliative stent or palliative chemo. Out of all 55 patients, the rate of malnutrition was 90%. There are generally high rates of malnutrition in patients with upper GI cancer, which is multifactorial. For example, patients can have mechanical or functional disorders of the GI tract, such as an obstructing esophageal tumour, and the cancers are often quite aggressive and lead to metabolic alterations and weight loss. And then the complications or side effects of surgery or chemotherapy can further worsen malnutrition. The statewide average of 65% was a point prevalence study, so may not have captured malnutrition throughout the patient's entire spectrum of care. However, we think that 90% is still quite a high rate of malnutrition. The average weight loss was around 17% in the active treatment groups and 27% in the palliative treatment group. Weight loss of more than 10% of body weight is classified as severe and can result in increased complications. We were limited in that all patients did not have a subjective global assessment, which is a more thorough method of diagnosing malnutrition. And weight change was the only data consistently available in the patient's electronic files. The presence of metastatic disease was much higher in the palliative treatment group, which may have contributed to larger amounts of weight loss. However, we also found that the patients in this group were less likely to see a dietitian. This demonstrates percentage weight loss throughout treatment for gastric cancer for a 74-year-old man with a T1N1 gastric cancer. He was quite well nourished on admission, at diagnosis, and had a total gastrectomy and insertion of a jejunostomy feeding tube, which was removed 6 weeks post-op as he was eating quite well. His nutritional status deteriorated during chemotherapy due to side effects and also inability to eat adequate sized meals after surgery. He was receiving nutrition counselling and oral nutrition support and was commenced on dexamethasone briefly. which improved his weight for a short period of time, potentially due to increased fluid retention, but this had no long-lasting effect, and by the end of his treatment he had lost 30% of his overall body weight. We looked at nutrition-related length of stay, and 1 in 5 patients had a nutrition-related admission due to weight loss or deconditioning, and average length of stay was 16 days. We looked at data around the time taken from diagnosis to an appointment with a dietitian, and found that our highest risk patient group are waiting on average 1 month to see a dietitian. The biggest gap appears to be initiation of the referral in surgical clinic and further delays with the referral being processed. One of our recommendations from this project is that all upper GI cancer patients are referred to dietetics at diagnosis. The referral processes are quite complex, and the reason for delayed referrals are multifactorial. For example, the upper GI surgeons work across multiple hospitals, which can make communication challenging, and there's no room availability to have a dietitian in the upper GI surgical clinic. One change that we've made already is to run a dietetics clinic at the same time as the surgical clinic, but in a different area of the hospital. And we've provided referral criteria so that the surgeons or nurses can page the dietitian when there's a high nutrition risk patient to be seen. We hope that improving referral processes will lead to earlier nutrition intervention and improved nutritional status. We also plan to develop a standardised nutrition care pathway to identify critical time points for nutrition assessment, nutrition intervention and escalation of nutrition care. We've presented the results to the head of surgery and at a surgical forum, and there are currently ongoing discussions between the Director of Dietetics and the surgical executive team regarding the results and the support needed for implementation of a pathway. We'll also be looking to work on our referral processes later in 2016. So some challenges we encountered during the project were resubmission of ethics being required, as mentioned earlier. Also, there were limited opportunities for consultation with the upper GI surgeons and oncologists regarding the project. Most communication with surgeons and oncologists was prior to the upper GI MDM, which provided very limited time. We also encountered unexpected barriers to nutrition that impacted on our ability to move forward with implementing a nutrition care pathway, such as challenges with communication between the multidisciplinary team. If there are any questions about this project, please feel free to email or call me on the contact number provided.